Perceive, process, perform. Do you need inspiration for your practice, or do you simply need to practice inspiration? With this series, we aim to do both. Give us 15 minutes and we'll give you practice inspiration. Professor Karen Baker has been on the dental college faculty at the University of Iowa for 35 years and occupies a unique role in dental practice and education. She is a clinical pharmacist with a master's degree in clinical pharmacology and therapeutics and is focused on patient-specific dental drug therapy.
Hello, my name is Karen Baker. I'm a clinical pharmacist at the University of Iowa, and I'm here today to do my confessions of an opiophobe. So I deal a lot with pain patients, acute pain patients in the dental setting, and I'd like to talk about how to limit or eliminate the use of opiates for post-procedural dental pain. So if you take a look at the first slide that you see is the World Health Organization pain ladder, and I think it's a bit misleading because look at the bottom rung of the ladder. The bottom rung of the ladder is the drugs that work the best for dental pain because dental pain is inflammatory. The next step is opiates, and the next step is stronger opiates, and the next step is really strong opiates where you're obtunded and you breathe 3 times a minute. So the problem is that patients assume that you have to climb the ladder to get good pain relief or strong pain relief. And I think that's one of the misconceptions that we have to battle. So Dr. Ken Hargraves originally coined this pain control strategy. And what you can see on the slide is that you've got nonsteroidals as the basis for any sort of bone or inflammatory pain. If you can't use nonsteroidals because the patient has a contraindication, a bad gut, patient's on an anticoagulant, then it becomes much more difficult to control dental pain, and you probably are going to have to use opioids. So I can't deny that opiates are going to have to be used there. So here we have the dental pain agents, and there aren't that many. Don't forget about good old acetaminophen or Tylenol or APAP, whatever you want to call it, as a very good basic drug. It's going to work centrally. The nonsteroidals work peripherally, and the beauty of it is the nonsteroidals and the acetaminophen work together and are synergistic. So anytime you can use synergy, you use it to your advantage. This is a huge issue for us in dentistry. So my advice is if you have a patient who's going to have moderate to moderately severe pain, initially you want to use the acetaminophen and the nonsteroidal in fairly high doses given at the same time on a scheduled basis for 2 to 5 days. You can certainly go to tramadol. It's a controlled substance, weak narcotic that you can phone in, and then you can go to opiates. And really the opiates that we use cannot be phoned into a pharmacy. They're both Schedule II. They're hydrocodone and oxycodone. I highly recommend that you don't use hydromorphone or the big D, Dilaudid. If a patient asks for Dilaudid by name, they have been around the narcotics block a few too many times. So again, when you look at dose response, what you see is that the steepest curve is for morphine. The problem is when you get up high on that morphine line, you aren't breathing anymore. And so what we want to do is stick with the drugs where you still can breathe and you can still walk and you can still perform daily tasks. So that would be your ibuprofen and your aspirin or acetaminophen. I'd like to give you a chart of the dental nonsteroidals because the nonsteroidals are really going to be the hub of what we do. I think dentists are the best at treating ambulatory pain of any of the medical professionals, and I do include in that emergency room physicians and the like. So you really have to be adept at using your nonsteroidals. If you look at that chart, what you see is that everybody knows about the propionic acids, but if those don't seem to be working or if the patient doesn't respect them because they can buy them at the deli mart, then you move to the ACs or acetic acids. They end in AC, and those are very effective as well, plus the patient doesn't recognize them, which gives you the benefit of about a 30% placebo effect in terms of pain. Remember, pain is a subjective sensation. So those are really the drugs that we would use. There are about 6 or 7 of them, and I would recommend that you use them at higher strengths than what's available over the counter. So as you look at the over-the-counter drug strengths and maximums, you see that acetaminophen is 4,000 milligrams over the counter, but only if it's being monitored by a prescriber, which would be you. And so we can let the patient go to 3,000 milligrams, but if they're on their own, on 3,000 is the limit, 4,000 if we are monitoring them. And notice that ibuprofen, if you actually read the box of ibuprofen, you're only supposed to go up to 1,200 milligrams a day. And if you remember that table I just showed you, we can go up to 3,200 milligrams a day. Naproxen sodium is Aleve. Over the counter, 660 is maximum. We will go up to 1,650. And therein lies the key. I know you're probably thinking, well, why do you have to go that high, or should we really use these doses? If you've got a young, healthy patient with a good gut and good kidneys, the reason that you do that is maximizing that nonsteroidal dose will maximize the anti-inflammatory effect. If all you wanted to do is treat a fever or generalized central pain, you could use 400 milligrams of ibuprofen at a time. We don't have an ideal NSAID. Certainly Celebrex is not an ideal NSAID for us, and it actually doesn't work very well for us. But we would like to see some sorts of pain meds in the future that would help to reduce the use of opiates in the United States, which is very, very high and climbing all the time. So the general prescribing guidelines are on the slide for you. And remember that if you have NSAID failure, nonsteroidal failure, what you should do is switch categories. Don't give up on the whole group. So switch chemical categories. Go from propionic acids to acetic acids. In terms of where you should start and where you should finish up, start with ibuprofen. It's the safest, it's the most widely used, and it's got an excellent track record. Schedule the doses and give 1,000 milligrams of acetaminophen every time you take your 600 or your 800 milligrams of ibuprofen, and do that 4 times a day on a scheduled basis for 2 to 5 days. There is a drug in the acetic acid category called ketorolac, and that one gives you a higher severity of the adverse effects that are typical for the NSAIDs, so you may find that that's of use as well. The strategies for dyspepsia, I mean, usually the complaint is, well, it upset my stomach, I had gastroesophageal reflux disease, and this made it worse. So I've got there, the big things are stay upright for 20 minutes and drink 8 ounces of water every time you take a nonsteroidal. If you do those 2 things, upright 20 minutes, 8 ounces of water, I think you'll find that the complaints of gastritis decline very, very, very rapidly. So it's funny when you say stay upright for 20 minutes, people look at you, well, what do you mean? Well, usually people take a sip of water and lie down. And those are the 2 worst things you can do. There are some problems with NSAIDs that you have to be aware of. The fact that some of your asthmatics, a fairly low percentage, will be prone to bronchospasm with nonsteroidals. Never prescribe nonsteroidals for the folks that you see on the screen there. Moderate renal failure. And of course, who is that? Are they going to tell you what their renal status is? No, but let me just tell you, if they're 85 years old, they're in moderate renal failure. So it's because they have old nephrons. So you want to look at it that way and say, anybody 75 and up, I'm going to be very careful about my dosing and limit the duration and definitely limit my doses. So the key points with the nonsteroidals would have to be, you've got to screen those patients for drug-drug interactions, drug-disease interactions. If the patient had good effect from, say, a surgical procedure last time with 800 milligrams of ibuprofen, please put that in the record, and you can use that again. Please write a prescription. You get better compliance. The patient usually gets the drug free if we're talking about generic nonsteroidal anti-inflammatories. Proper ingestion technique, and the drug of choice, the DOC at the very bottom, is ibuprofen 3,200 milligrams in 24 hours. Here's some points about dental pain control. One is that codeine alone, or even codeine with acetaminophen, is really just not worth anybody's while. It's just a bad drug. It's widely ineffective, and it's really, really constipating, which just makes unhappy patients. So that one I would skip if I were you. If you're thinking tramadol might be an intermediate measure for you, the problem with tramadol is that it's not very potent, and it does have some contraindications and warnings. So my key points with tramadol are, again, if a patient is allergic to codeine or codeine derivatives, they cannot take tramadol. And I think that's a very important point, because that was not known when it was first marketed here in the United States. Well, that leads us to what I'm phobic about, and that would be the opioids. So I've saved them for last. And remember, I think we should regard opiates as rescue medication and not first line in dental inflammatory pain. So the common adverse effects are there. So as you look at those adverse effects, the first thing that jumps out at you is, I don't think this patient is going to be very ambulatory or active, and that's absolutely correct. So why would a patient want to feel like this? I think some patients expect to be knocked out and to have no sensations whatsoever, and that to them is pain relief. So I think we need to explain our goal, and our goal is 30 to 50% reductions in pain sensation to the point where you can function during the day and get to sleep at night. We don't seek elimination of pain. That is not our ultimate goal. So as you look at that list, you say, yes, I know about these things, except what about this allergy, pseudo-allergy? And I do want to point that out. There is such a thing as true allergy to opiates, which is very rare, and there is a common occurrence called pseudo-allergy. Pseudo-allergy means that you take an opiate and you release histamine. So you degranulate mast cells and you release histamine, and look at what happens when you do that. Hypotension, flushing, itchy palms, sweating, but you notice there's no hive formation, no urticaria, no head and neck swelling, no respiratory distress. Very, very important. So it doesn't depend on whether you've had prior exposure either. I want to show you that the risk of pseudo-allergy is more common in the low potency opiates, and it's very important to see that the highest risk of this allergic reaction happening are with meperidine or Demerol, codeine, morphine. Those are the three. So when your patient says, oh, I'm allergic to codeine, and they circle it on their health history, and you say, so what was your reaction? And they say, oh, it made me so sick, and I got all dizzy and sweaty, and I threw up. Classic pseudo-allergy. Why do we differentiate? Because I don't want you to feel as if you have no choices when a patient tells you they're allergic to codeine. Allergies to codeine are typically pseudo-allergies, and if you get a good enough history, you can determine that. So what do we do once we get that history of pseudo-allergy? Try the acetaminophen nonsteroidal combination first. That's obviously what I laid out at the initial discussion. And decrease opioid dose if tolerated. My best strategy for you, and we do this every day, is give the patient a bottle of Benadryl, generic Benadryl oral solution, and have them take 25 milligrams of it half an hour before their first opiate dose. What does that do? It covers up histamine receptors. So even though they release histamine, histamine doesn't activate the receptor. In other words, no reaction. And it also gives you a little bit of an antiemetic effect and a little bit of sedation. So it's a very nice combination. So if you have a good pseudo-allergy history, pre-medicating with diphenhydramine 25 milligrams, especially in liquid form if you've just done an oral procedure, is an excellent way to minimize or prevent basically pseudo-allergy. You can expect all these opiate side effects. Anybody who tells you they don't have side effects wants more opiate. And so be very aware of that. A patient has absolutely no side effects, nothing is wrong at all, I need more, I took all 20 of them in 24 hours. Okay, something's really wrong with that picture. The vast majority of your patients are going to complain about the side effects of opiates. If you look at the narcotic analgesics, I did want to point out the equa-analgesic doses that you see there. 5 milligrams of hydrocodone is equivalent to 2.5 milligrams of oxycodone. Now, the reason I show you that is that oxycodone might be the best choice for a patient who's a big histamine releaser, because oxycodone gives you much less histamine release than hydrocodone. So I also just left propoxyphene in there for kicks because propoxyphene was taken off the market in 2011, but I wanted you to see that it wasn't very potent, and we really don't have a substitute for propoxyphene anymore, but propoxyphene was never a very potent drug. Should you ever prescribe oxycodone alone? The answer is no. You'll be known as Dr. Euphoria if you do that. So no oxycodone, I should say, alone. There is no hydrocodone alone in a low enough dose for us to use in dentistry, so that's not even a question. Here are the 6 strengths of Percocet, so you do have to specify if you're going to write oxycodone or acetaminophen, and typically it's the second one down, the 5 milligram for 325 that would be used. When you look at the chemical categories, and I know this looks like your old farm text, but you've got to know that anything codeine, codone, morphine, morphone is in the same group. So if a patient has a true urticarial or head and neck swelling or respiratory embarrassment reaction to this group, they can't have anything else in the group. It's very important to recognize that. They could have this group then if they're truly allergic to the morphine, morphone, codeine, codone. And these groups are variably tolerant, but remember, tramadol is a derivative of codeine. So if the patient is total body hives to codeine, they cannot have tramadol. So remember, pseudo-allergy, no urticaria, no angioedema, no airway involvement. It's most common with codeine. And remember, perception is reality with analgesics. So I talked about this at the outset, but I just want to reemphasize that patients believe only narcotics are strong, and it's up to you to convince them. And thank you very much.